we have. So it's an absolute pleasure to have Dr. Nanette Wenger presenting cardiac grand rounds today. She's a professor of medicine at Emory University. It is no understatement at all to say that Dr. Wenger is a living legend and has had a life and career that is composed of many firsts. I will do my very best to summarize so we have time to actually listen to her. After undergraduate degree at Hunter College in New York, she was one of the first women to receive a medical degree at the Harvard Medical School. She completed residency at Mount Sinai and cardiology training at Emory University, afterwards joining them as one of their first female faculty at Emory and also at Grady Memorial Hospital. There is an amazing faculty picture from Emory early in Dr. Wenger's career, where she really is this one woman in the middle of a sea of men. And I think that, sort of gives you an idea of what life was like when she joined the faculty of Emory. Another thing that I loved and sort of, reading through her story was seeing this anecdote that was published in the Atlanta Journal-Constitution about a young Nanette Wenger in Grady in 1958, at a time where patients were still separated by race, who came in and insisted that things would absolutely not be done that way under her watch. I think that was perhaps one of the early signals that this is someone who would be challenging the norms and accepted paradigms where necessary. Beyond being just the first, I think Dr. Wenger's career has been visionary and impactful in areas and domains that are incredibly relevant to all of us today. She has authored more than 1,500 papers and articles and reviews and guidelines. She was really one of the first to detail the importance of early ambulation and physical activity following myocardial infarctions. This was a Grady 21-step program, really leading to the establishment of the field of cardiac rehabilitation as we know it today. She was also one of the first to fully describe coronary heart disease in women and gender differences in cardiovascular disease, highlighting the fact that heart disease in women was, and still is, often under-recognized and undertreated, and a major contributor of mortality and morbidity in women. Really one of the leaders and establishers of the field of heart disease in women and women's heart health. Another seminal area of contribution has been her focus on geriatric cardiology and on heart disease in the elderly. Really, her career, I think, has been characterized by shining the spotlight on significant populations that understand and improve heart health. Now, if there's an award in cardiology or medicine that exists, she has probably already won it. So we're not going to go through the whole list. If you're talking about the American Heart Association's Physician of the Year, or the Gold Heart Award, the highest award of the AHA in 2004, the Lifetime Achievement Award from the ACC, the inaugural Distinguished Mentor Award from the ACC. So rather than list all the awards that she has won, I thought that it might be most helpful and it might take less time to talk about what she has not won yet. So Dr. Wenger, please let us know when the Nobel Prize Committee calls so that we can update your CV accordingly. She has served at the highest levels of the AHA, the ACC, has advised the WHO, NHLBI, and all the major organizations in our field. Although her career has really been characterized by many firsts, I think it's important to know that she has ensured that she is not the only. Dr. Wenger has been a force in the promotion of women in cardiology, even from the time when it was often the singular, the woman in cardiology. She has been an incredible mentor to many men and women in all stages of the journey in cardiology, from students, medical students, trainees, junior faculty, other faculty. She really is a role model to many in the field, myself included. So, in summary, she's the first but not the only visionary, impactful, distinguished mentor, woman cardiologist. I think we will all, be so much, grateful to do even a fraction of what she's done. So it's an absolute pleasure to have Dr. Nanette Wenger join us today, talking about a topic that I am particularly passionate about, which is updates in prevention of ASCVD. Dr. Wenger.
Well, it is a delight to be with you, even though remotely. And our conversation is going to be rather interesting because probably 8 or 10 years ago, we had a very simple singular risk assessment tool. We were treating lipid abnormalities on very limited, simple guidelines with statins, and thought we were doing a good job. And then as we began the task of self-examination, we realized that we could do much better with risk assessment, and more drugs came on the scene, so that we now realize we can do much better with management. And that is the substance of what we will review this morning. These are my disclosures. And this is the pathway we will take in our conversation. We'll talk about the key concepts that underlie the multi-society cholesterol guidelines, and a lot of the emphasis will be on triglycerides, probably called the forgotten lipid. We'll talk about the clinical trials update, because we do have some new and exciting trials in the lipid area, and particularly look at the omega-3s as statin adjuncts in cardiovascular prevention, because that is, if you will, the new kid on the block. And then I want to highlight with you some practical considerations. What is it that we do in our practice as we use statins and as we use statin adjuncts? So we're really in a new era, as I've suggested, of atherosclerotic cardiovascular disease prevention, particularly as regards lipid management. And all you have to do is to look at all of the headlines in the journals and in the press to see that almost every day we see something new and something that is added. At the same time, as we'll review a bit later, our patients are seeing both this information and some of the misinformation that we have to counteract. Now, to summarize a rather elaborate guideline, the multi-society guideline certainly reinforces lifelong healthy lifestyle, which is the basis for prevention. But now we have not just the ASCVD risk estimator, but we have a plus version, because this plus version can track for you on the document the potential benefit of risk-lowering interventions. So you can show your patient not only their risk, but what will happen if that risk is lowered. And at least for a subpopulation, can track the changes over time. So this is a rather sophisticated test, and I find that my patients like this in our conversations. But we're trying to simplify a bit the 10-year ASCVD risk score and put it into 4 buckets: low, borderline, intermediate, and high. Because that, I think, is a concept that patients will understand, and they'll understand where at least we project that they have very little choice in the high-risk subset, because the risks are so high and the benefits are so great. But in the borderline and intermediate, this is where the discussions take place and where patient preference becomes important. We'll talk just a bit about coronary calcium, which is something I like very much, because I think it is a helpful variable in discussion. And then we'll talk about some of the risk-enhancing factors that I think have really enhanced, if you will, our discussion with patients. Well, what do we do? This is the ACC's Risk Calculator Plus, and the calculator can assess low risk, and you see the percentages there, borderline, intermediate, and high risk. And what it does is it estimates the risk for heart events at patients in a larger age group. The lifetime risk predictor is perhaps in a narrower age group, only 20 to 59. And it is really the idea that you have this on your tablet or on your screen as you talk with the patient, and this is the basis for some of the risk discussion. And remember that a level of 7.5% identifies statin eligibility, but not a mandatory prescription. This is some of the discussions you have, and then you use the new ACC-AHA primary prevention guideline algorithm. You're all familiar with this. You use it in clinic all of the time, where you put in the variables and the collection comes there. But the issue of on hypertension treatment, on a statin, on aspirin therapy, etc., allows you to show the patient what their risk is now and what the risk would be if a therapy is instituted. Now, the risk-enhancing factors, I think, are really important because this is what makes us have a discussion with patients, because even with the same numbers, patients are very, very different. So all of these are risk-enhancing factors. If there's a family, excuse me, family history of premature atherosclerosis, primary hypercholesterolemia, metabolic syndrome, which is so common, chronic kidney disease, chronic inflammatory conditions, and then some that are specific to women, premature menopause, or any of the pregnancy-associated conditions, particularly the hypertensive complications that increase risk. I see such a diverse population in my clinic because we are an immigrant city. And we see so many of the high-risk race ethnicity, particularly the South and East Asian, Middle Eastern, and Native American populations. And that's a variable that has to be taken into account as you talk both to patients and to families. And then the high-risk levels of lipids or other biomarkers, persistent primary high triglycerides. Again, triglycerides, almost the forgotten lipid. And then it doesn't say to measure these things, but if they have been measured, you use them. An increase in high sensitivity CRP, an increase in Lp(a), an increase in ApoB, or if there is a decreased ankle brachial index, evidence of peripheral arterial disease. Now, the cholesterol guidelines talk about who is a candidate for coronary calcium measurement. And I use it probably for many of these variables. There are many patients who are reluctant to initiate statin therapy because they've heard so many bad things about statins. And often they really want to know what their risks are. Patients who've had statin-associated symptoms, and we're trying another statin. Older patients who say, well, I don't have that much risk. I've lived to older age. Would I benefit from a statin? And then the middle-aged adults who have borderline risk, and many of them may have the risk-enhancing factors. But for all of these, Coronary calcium, I think, is very helpful simply because we know that coronary calcium equates to atherosclerosis. And this is a visual image for patients and sometimes is of great help deciding yes, or if the coronary calcium is virtually zero, saying, well, if you're not terribly happy about statin therapy, perhaps you are not a candidate for statin therapy. Now, what constitutes the high-risk patient? And these are the ones where I must admit I use all my powers of persuasion to see if I can get the lipids as low as they can go. And the major ASCVD events are recent coronary syndrome, MI, stroke, symptomatic peripheral arterial disease, and then all the high-risk conditions that you know. The familial hypercholesterolemia, the history of revascularization, diabetes, hypertension, kidney disease, smoking, elevated LDL, and a history of heart failure. And the fact is, they are at very high risk if they have more than one major ASCVD event or one major and more than one high-risk condition. But this is really a nice list, and the patients can see, are they high risk or are they very high risk? Now let's talk a little bit about triglycerides. And what we see is that even though over the years, and here you see the serial trials in the secondary prevention, the high risk, and the primary prevention, that even though you decrease the risk with statin therapy, substantial cardiovascular risk remains. And that substantial cardio risk, some of it is lipids, certainly, but some of it is the lack of control of hypertension or diabetes or the persistent smoking behavior. So residual risk is not solely lipids. It is really the total risk spectrum for the patient. And what we see and haven't paid much attention to previously is that even though the LDL is at goal on statin therapy, if there is a residual high triglyceride, that predicts risk. And probably one of the reasons we haven't paid much attention to it is that we've not had much in the way of effective therapy that reduces triglycerides. Now, here's the way we classify, per the AHA and NLA, the way we classify fasting triglycerides. And for triglycerides, fasting is important. Less than 100 is optimal, less than 150 is normal. The borderline level is 150 to 199, the high level to 500, and over 500 is the one that we know clinically, because here is where we have the risk of pancreatitis. And previously, those were the patients that in clinical practice were very commonly treated, and the treatment was really to avert the pancreatitis rather than for cardiovascular risk. But I want to share with you these data that the fasting triglyceride is strongly related to cardiovascular risk, even at very low levels. Now, what is it about the triglycerides that impart risk? And again, most of these data derive from observational studies, but they are fairly strong studies. And then as you try to look for causality, you say, what is it in the triglyceride spectrum? And here I've listed all of the variables that are important. And the triglyceride-rich lipoproteins promote inflammation much more than LDL. And remember that as we understand it today, that atherosclerosis and active atherosclerosis is probably a combination of lipids and inflammation. And the fact is that the remnant lipoproteins are more likely to get into the macrophages than is simply LDL. Now, what is the basis for our clinical decision making? And the randomized clinical trial has been the holy grail of all of our therapies. And in cardiology, we have them abundantly so. And what I want to do is to look at categories and say, we have statins as a basis. So now we're looking at statin adjuncts. How can we do better than with statin alone? And we have recently ezetimibe, PCSK9 inhibitors, the fibrates, and niacin. And the fact is that the positive studies, and I'm not going to go over the numbers that specifically, have been ezetimibe, unquestionably in the IMPROVE-IT trial, and the PCSK9s in Fourier and in Odyssey. But the fibrate and niacin studies have been very disappointing. Accord and Field and Aim High and HPS2 Thrive. They have not met any of the goals. And I think for all practical purposes, at least for the substances available today, that has taken the fibrates and niacin out of our clinical armamentarium, so that when we look at statins, we're looking at ezetimibe, which many of us use very, very commonly and frequently because it's inexpensive. And then the PCSK9s, which are very effective, but also very costly. 2 new studies, and this is one on bempedoic acid, but remember, this is, although it's approved by the FDA, the study that we have is in statin intolerant patients. So we really don't know about this drug as an adjunct yet to statin therapy. It's being looked at, but this paper, which is 2019 from the Journal of the American Heart Association, is in statin intolerant patients. But these are the data at this point. And then a very interesting study as a statin adjunct, and that is the Orion study looking at inclisiran, and again, showing a persistent lowering of LDL over time with a sizable lowering of LDL. I've not yet seen any substantial uptake of this drug, and as a matter of fact, I have not any personal experience in its use, only trial experience. But then what has come on the scene have been the omega-3 fatty acids. And there have been trials aplenty, and I've listed most of them for you on this slide, but most of them initially were with dietary supplements. Remember that dietary supplements are only minimally FDA regulated, and we are really not sure with dietary supplements exactly what's in them and whether from one brand to the next or from one batch to the next, they're even constant. And really with most of them, if you look at the bottom of the slide, they've been combinations of EPA and DHA, so not pure EPA, save for one, and that is the JELIS trial. And I'll talk about that in a minute, because that was pure EPA superimposed on a statin, and it had a favorable effect. But this is a sizable trial, some 18,000 patients, but it is an entirely Japanese study. And whether it can be extrapolated to the rest of the world, uncertain. But this is really the first study that suggested that there might be something in pure EPA that was very valuable. And I think that led to the trial that we will talk about next. The 3 trials that have come across recently have been REDUCE-IT, and I'm going to spend a fair bit of time looking at that in detail because that is the one that had a 25% relative risk reduction in MACE, which was quite impressive. The ASCEND trial, which did not meet its endpoint, and VITAL, again, which failed to meet its endpoint. So as we look at the trials, we have only REDUCE-IT, that met its endpoint. And I must admit, it was very impressive. If you look at the bottom of the slide at the p-values, you probably will have difficulty counting the number of zeros there. But the primary endpoint of multiple events was very impressively reduced by icosapent ethyl, very impressive, as were the key secondary endpoints. And there were, interestingly, a sizable number of women, and there were no gender differences in the outcomes. And then Deepak Bach and his associates did something very interesting that we've not seen with many of the trials, because the trials usually look at the first endpoint and then the patient is censored. But here they looked not only at the first event, but they tabulated second, third, fourth, and fifth events. And in REDUCE-IT, there was a reduction not only in the first event, but in the total events. And again, very impressive with the p-value with many, many zeros, as you can see. And this is an extrapolation. It's an interesting extrapolation, and I use it to talk to patients. And what they said is that if everyone in the US was on 4 grams of icosapent ethyl daily for 5 years, this would be the anticipated improvement in cardiovascular death, in fatal or non-fatal MI, stroke, marked decrease in coronary revascularization, again, based on the trial data, and a decrease in hospitalization for unstable angina. But I think what's impressive to me about this trial is that there was benefit across a whole spectrum of endpoints, which says that we're doing something to the basic disease process. And then looking at the on-treatment serum EPA, you can see the area under the curve looking at the daily average EPA levels. Now, again, because the results were so robust and because there was the inclusion of many patients who had substantial comorbidities, the different endpoints were examined and reported in the literature, and the benefit was seen without established CVD, but with diabetes and other risk factors, with established CVD and diabetes, and again, with established CVD without diabetes. No matter how you slice and dice it, the subgroups all had very, very substantial benefit. And what's coming down the pike? What is it that we might see? The study of EPA and DHA in the STRENGTH trial was recently stopped for futility, and there is an ongoing trial that will not be reported at any of the upcoming meetings simply because it has a good time to go. So again, this is a stay tuned for more trials, but what I've shown you are the data that we have to this point. So let's spend a little bit of time talking about EPA and comparing it with the other fish oils that are available. And simply this is to show you the structure of the omega-3 fatty acids. And you can see that they differ very, very markedly. And only 2 of them seem to be effective for triglyceride lowering, and that is the EPA and the DHA. And importantly, and I'm not going to go into the details, but just look at the slide and you'll see that they're very different molecular structures and very different actions related to those molecular structures between EPA and DHA, so that the 2 of them are certainly not equivalent. Now, when you look at the decline in cardiovascular disease with icosapentaethyl, it didn't vary at all by the baseline triglyceride. And I think that that is one of the concerns that has let us try to explore what is the mechanism. It works, but we're not sure what is the mechanism, because the baseline triglyceride, whether it was above or below 150, did not seem to make a difference in the efficacy of this drug in lowering cardiovascular risk. So here is a list of the potentially benefit effects on proatherogenic mechanisms, on endothelial dysfunction and oxidative stress, on inflammation and plaque growth and unstable plaque. And all of them are candidates, but I'm not sure that anyone specifically has been the one to say, aha, this is how it works. And it may be that it is a combination of these, and it may be that it is the combination of several of these variables that makes this such a very effective drug. But there is a lot of work ongoing in the basic lab to see if we can tease out what is there in the endothelial dysfunction, in the inflammation, in the instability of plaque. Because as I've said, we've seen benefit across the spectrum of MACE events. So the question is, if we look at the icosapentaethyl effectiveness, reducing triglyceride-rich proteins and inflammation, is it hemostatic? Is it antiarrhythmic? Is it inflammation? Is it oxidation protection? Is it biosol, dense LPL, or other EPA effects? We're not sure. And my guess is it's likely a combination of many of these. Now, you can go into any health food store and buy fish oil dietary supplements. And all you have to do is to turn on the television, and there are dietary supplements from one end of the television advertising to the other. As I've said here, they're poorly regulated, but widely used. Remember that these are non-prescription and they're only dietary supplements, and the FDA oversight is virtually absent. And as we all know, dietary supplements are not recommended to treat disease because we have absolutely no data from them. But if you listen to the television, as your patients and mine do, heart, brain, vision, inflammation, skin, fat, depression, cognition, pregnancy, childhood behavior, bone, name it, benefits are claimed for fish oils and other supplements. And the fact of the matter is about 8% of US adults take some kind of a fish oil supplement. And I must admit, I have a significant difficulty trying to review with my patients that these are unregulated supplements and very different from prescriptive medication. And just looking at the leading dietary supplements, there are different proportions of EPA and DHA and saturated fats and other fats. And actually, many of the fish oils have a substantial amount of saturated fat. And the omega-3 content may be overstated. And this is what the patients don't realize, that in some of these, they may be having an intake specifically of saturated fat, and the EPA and DHA doses are not the same as in the prescription medications. So, what do we do in our clinical practice? You and I are seeing patients with lipid abnormalities with either high risk coronary disease or established coronary disease. How do we put all of these data together? It's really easy in terms of the statin. The high-risk patient gets a high-intensity statin, the moderate-risk patient gets a moderate-intensity statin, and the low-risk patient gets a low-intensity statin. And what we mean by a high-intensity statin is that the trials have shown us that taking it regularly will lower the LDL about 50%. And that's fairly uniform among patients. So if you want an LDL lowering of about 50%, it's a high-intensity statin. Moderate intensity statin will lower the LDL between 30 and 50%, and the low intensity certainly not as much. But again, this is a very good chart to show patients because many of them have seen the statin A or statin B or statin C, and different ones of them have been prescribed different ones over time. Remember, because some of these are much newer than are the others. Now, early on, when there were not specific LDL targets anymore, people stopped measuring LDL. Now, I think what's happened is that with the statin guidelines, patients were not getting their LDL measured routinely every 3 months. That was a waste of testing and a waste of blood. But that doesn't mean that you don't test. You should repeat the lipid measurements after you start statin, really because you want to assess both adherence and the percent response, or the same thing if you adjust the dose. And probably repeating it about every year. I don't repeat it every 3 months as needed unless I'm adjusting doses. But I think that the adherence can be assessed because most patients fall within the spectrum that I outlined for you. And again, responses to lifestyle and statin therapy are really defined by the percent reduction compared with the baseline. Now, challenge is the adherence to statins. And when I talk to patients about their cardiac medications, I don't say, are you taking your medicines or do you have difficulty with your medicines? I'll usually start by saying, how many times during the week do you think you miss medicines? And that's essentially giving them permission to tell me that. Excuse me. The fact is that statins are very well tolerated, although there is no question that patients report statin intolerance. We know they're enormously effective in preventing initial and recurrent ASCVD and have been probably one of the major contributors to our decrease in cardiovascular mortality. And the fact is there are very few serious adverse effects. Virtually no rhabdomyolysis, virtually no hepatotoxicity. We don't even test for hepatotoxicity. And the statin-induced diabetes is probably most prominent among the menopausal women. But the fact is that a large proportion of patients will decrease the statin. It's been estimated that in a year, probably about 40% of patients have discontinued their statin therapy. And I expect some of it is that we have not emphasized enough the importance of continuing it. Because often the statement that we make is, your cholesterol is great, but we don't finish the sentence. The rest of the sentence is, your cholesterol is great because you are taking the statin. And then I think that if the patient has reported statin intolerance, you either change the statin or start with a lower dose and creep up, because many patients on rechallenge can easily take a statin therapy. But I think we have to have conversation with patients about the statins, and in the symptomatic coronary patient, if they stop taking any of their medications, as in the heart failure patient, they know it because they develop symptoms. They don't develop symptoms when they stop a statin. So we really have to hone in on that very carefully. And then, what about the statin adjuncts? That's really where we've gone in this talk. What about fibrates, niacin, ezetimibe, or PCSK9 inhibitors? The fact is the statin fibrate combination is not effective in any of the studies, as I've shown you, and not recommended. And the same issue is the statin niacin combination. No additional benefit, and actually may increase risk and have side effects. So statin niacin, not recommended. And as I've shown you, for patients with diabetes and ASCVD, if you don't get the cholesterol to desired levels, consider adding additional LDL lowering agents. And I've shown you the trials that show the efficacy of ezetimibe and PCSK9 inhibitors with a major difference in cost. The PCSK9 inhibitors have become less expensive, but they remain costly drugs. So when you say, what is it that you can add to a statin to reduce the ASCVD risk, you have two pathways. You have the LDL lowering pathway, where after optimized statin therapy, you add either ezetimibe or a PCSK9 inhibitor, or both. And you have the triglyceride-related pathway, where you add icosapentaethyl. And the interesting feature is looking at triglycerides in patients who take and do not take statin therapy. And there's no question that what you see with statin therapy is that there remains an elevation of triglycerides, even in statin-treated patients. And now we have a new indication by the FDA for icosapentaethyl, and that's based on the REDUCE-IT trial. Remember, this was a drug that was on the market. The original indications were to reduce triglyceride levels in adult patients with severe hypertriglyceridemia. But the fact is that even in those studies, there was not a good study examining the risk for pancreatitis with this daily dose of 4 grams a day. But the new indication, based on the data I've shown you from REDUCE-IT, is that it's an adjunct to maximally tolerated statin therapy to reduce multiple risks: myocardial infarction, stroke, revascularization, unstable angina requiring hospitalization, in adult patients with elevated triglyceride levels, either with established cardiovascular disease or with diabetes and 2 or more additional risk factors. Now, this label is based on the design of REDUCE-IT, and those were the patients who were in the REDUCE-IT trial. Now, even though we don't have a new guideline, we have recommendations from many of the scientific societies, from the diabetes group, from the European Society of Cardiology and Atherosclerosis, to the National Lipid Association, American Heart Association, American Association of Endocrinologists. And basically, the details of their recommendations differ, but based on the REDUCE-IT trial, they recommend the addition of icosapentaethyl at the dose of 4 grams a day to a statin for reducing heart events per the REDUCE-IT trial. Now, all is not perfect. And the fact is that icosapentaethyl was associated with an increased occurrence of atrial fibrillation or flutter requiring hospitalization. And it was greater in patients who had a previous history of that. Obviously, there is a potential for allergic reactions, and it's not known whether the patients with allergies to shellfish are at increased risk of an allergic reaction. That could not be determined from the trial. There was an increased risk of bleeding, but it was much more prominent when there was concomitant aspirin, clopidogrel, or warfarin. But these are the things that you look for when you prescribe icosapent-ethyl. So we've covered a great deal of ground. Let me try to summarize where we are as of August of 2020. The 2019 Multi-Society Cholesterol Prevention Guideline. First, improved risk assessment using the Risk Assessor Plus. Again, lifelong healthy lifestyle as the basis for all preventive efforts. And I want to emphasize that because back when I was a medical student, the late Dr. William Cannell of the Framingham Heart Study fame used to say, why is it that doctors during an office visit don't address lifestyle? And he said, you know, you have 15, 20 minutes on an office visit, which was back then, now it's about 10 minutes. He said, but physicians hate to tell patients what their mother-in-law would have told them for free. And I think what we have to do is probably pick up that mother-in-law role and emphasize a lifelong healthy lifestyle. The prevention guidelines emphasize on treatment levels. What are the goals? What is it that you want to achieve based on which bucket the patient is in, low, borderline, intermediate, or high risks? And then if the LDL is above the threshold with maximum tolerated statin, add ezetimibe or a PCSK9 inhibitor. Then there are 6 new statements, and I've shown them to you on a prior slide, saying if despite LDL control with statins, and if there's prior disease or diabetes with an additional risk factor, then use 4 grams of icosapent-ethyl to decrease cardiovascular disease. And the important thing is that the non-icosapent-ethyl and the supplement omega-3s are not recommended. It is this specific preparation that was studied in the Reducer trial. So this is the new FDA indication for icosapent-ethyl that I've shown you to decrease cardiovascular disease. And in implementing this new guidance, consider statin rechallenge if the patient has had prior problems with statins, and then consider statin adjuncts to lessen cardiovascular disease. Ezetimibe and or PCSK9 inhibitors for residual LDL elevation, and then icosapent-ethyl for triglyceride elevation. I think we have covered a great deal of ground. I thank you for your attention, and we'll open the floor for questions, concerns, comments.
Dr. Wenger, thank you so very much for that excellent talk and excellent review. Like I mentioned earlier, the chat's open for any additional questions that people have. We've had a few questions already come in, some of which you've already addressed sort of in the course of the talk. There's a question here from Ramon Peralta asking if there are any circumstances where it is difficult to establish a correlation between the 10-year cardiovascular risk and metabolic syndrome. So are there circumstances where you either cannot establish that or there's a significant discrepancy between the cardiovascular risk assessment and underlying metabolic syndrome?
Well, remember that the metabolic syndrome is a composite of features. And this is why it's listed as a risk enhancing factor. So that if the standard ASCVD risk is in the intermediate risk and the patient has metabolic syndrome, that may mentally push you into a higher risk. And that's why I have this list on my computer, so that in the office or in the clinic, I can show this to the patients and say, well, if you didn't have this, perhaps the statin therapy would be more variable, but here you have this. Or if you weren't a South Asian, I might say you have a choice, but as a South Asian, you have a higher risk, and therefore this would be my recommendation. But again, it becomes a discussion, and remember, patient preferences become very, very important. Many patients will say to me, well, let me try to change my diet, let me try to exercise more, let me try to lose weight. But you have to realize that the dietary cholesterol intake is such a small proportion that you may get a small change in LDL with diet, with exercise, with weight loss. But it's very unusual to see a major change. Some of the patients who've gone on various fasting regimens, and there's no clinical trial of fasting, but anecdotally, many of them have lowered their LDL cholesterol. And I'm not sure whether it's the weight loss or whether it's the fasting or what it is. But I'll tell the patients, of course, this is what you want to do. Try it. We'll come back in 3 months. We'll come back in 6 months and see.
Yeah, that's great. I have another question here from Erica Spatz. Dr. Spatz is actually directing a new preventive cardiovascular disease program. She's commenting on having somewhat of a hard time getting fully behind ezetimibe, given that the prior studies were negative and very modest effect sizes. I noticed that, when you talk about, the next step beyond statins, you're saying ezetimibe, well, and or PCSK9 inhibitors, but keeping in mind that the effect sizes for those are quite different, even though sort of in the insurance pathway, we sort of have to show based really on cost that ezetimibe has not been as effective in risk reduction before moving on to the PCSK9. So don't know if you can sort of comment on that, ezetimibe or PCSK9 and how we should be looking at that.
Well, remember that ezetimibe will give you on average a 15% reduction in LDL. So if you know that you need more than that, I would go directly to the PCSK9. For the patient who is borderline, ezetimibe, I think, will be helpful. Many of the insurers require that you have both the statin and ezetimibe before they will give prior approval for a PCSK9. So some of this is insurance dependent, but I don't know that you can expect more than a 15% lowering of LDL with ezetimibe.
Okay. And we have another question here from Jim Refkin, sort of bringing in a little bit of the forgotten stepchild here of HDL-C. So he asks, have we pretty much, given up? Are we done with HDL, given the failure of the CETP inhibitors? Or is there an additional, story with HDL?
Well, we spent a decade trying to raise HDL, and a number of trials and a number of preparations. Some of them raised HDL, but increased adverse events, and none of the trials were effective. Now, were we doing the wrong thing? Were we using the wrong drug? Don't know. But the fact is, we do not have an HDL raising drug that has produced clinical benefit. Now, one of the features that has surprised everyone is that the very high HDLs probably are not protective, in that there is a different composition within the very, very high HDLs. So the idea of adding and subtracting HDL and LDL, I think, has gone by the wayside. Is it not a target? It may yet be, but we haven't found a way to do it. And I've not seen much enthusiasm simply because of the adverse effects that were seen with so many of the HDL raising drugs.
Great. We have more questions. We're generating a lot of questions, which is great. I'm asking Dr. Bender, I don't know if you can unmute for your comment and question.
Nanette, hi, it's Jeff Bender. Terrific talk, and thanks for joining us. Wish you were here in person. I was just wondering, the mechanisms that you described potentially for the IPE effect, those of improving endothelial function, reducing oxidative stress, reducing vascular inflammation, have all been shown in various forms with statins. And I'm wondering if there are any mechanistic studies that have looked whether there's synergy between IPE and statins mechanistically, or are they additive, or if you use one, you don't need the other from a basic standpoint. I'm just kind of trying to wrap myself around having similar effects with very different classes of drugs.
Well, again, I expect that these are studies that are ongoing, but if you examine the clinical trial data, the icosapent ethyl has only been examined superimposed on statin, so that obviously there is an additional mechanism to the statin that has enabled this very prominent decrease in events. Now, would it be seen absent the statin? We don't know. But at the moment, I think this is something that is being looked at in the lab, mainly because we don't have a specific area to say, here we have a drug that is doing a 25% lessening of MACE. But why? What is it in its action that is allowing that to happen? And I think all of us are mechanistically inclined and want to see that information. It's not available yet. And as I said, it may be that there are multiple actions. This is a very complex molecule, but there is certainly a great deal of work ongoing in the laboratory trying to answer your questions, but no answer to date, and certainly nothing in the published literature.
Thank you.
I ask Dr. Velasquez to comment.
Dr. Wenger, first of all, thank you so much for a wonderful talk. It's great to see you, and on behalf of the section and the Heart and Vascular Center, we really appreciate you taking the time to spend with us this morning. My question relates to implementation. So as you know, over the decades, you have contributed, among many others, just this remarkable amount of data to support risk reduction. There's been a lot of work on the construct of a polypill. And what I want to get your feedback on was, now with IPE and its relatively limited adverse effect profile, do you feel that this is going to be kind of something that will be studied, particularly as it relates to population health and global settings, as part of a polypill? And what are your thoughts in general about the construct of polypills for risk reduction?
I expect that in third world communities where cost is a major issue, where access to medications are a major issue, that a polypill may be the way to go. In the clinic, I think we've all seen adverse responses to so many components of the polypill. So many of the patients with a tremendous burden of cardiovascular risk factors also have renal disease that may be adversely impacted even by the low doses of some of the substances in the polypill. We're now looking at challenge to aspirin therapy, not using it routinely for primary prevention because of bleeding risk. Would a very low dose aspirin still impart some bleeding risk? So I expect that where this is the alternative to nothing, a polypill is really good. But I've not been a tremendous fan of a polypill, although I must admit that now combination medications in one tablet I'm using because of ease of patients taking medication. You know, one of the things that we have to do as we see patients in the clinic is to see how many medications they're taking and to see, are we prescribing an unreasonable number of medications? I don't think we see it as much in the primary prevention spectrum, but I think that in the patient who has coronary disease, diabetes, hypertension, hyperlipidemia, et cetera, and then has a number of other comorbidities, we see patients being prescribed 18, 20 medications. Now, you know, years ago when we used to handwrite prescriptions, we realized how many medications the patients were taking because we realized how many medications we were handwriting on the prescriptions. Now that we check boxes on the computer, I don't think we appreciate that as much as we did in prior years. And even though we think that we're doing guideline-based medical therapy, some of the times we have to look at de-prescribing and say, are there medications this patient is taking that they don't need anymore? Was something given for an intercurrent illness that has been continued? Is there a prescribing cascade? Was the patient given a blood pressure medication that caused edema, and therefore we gave them a diuretic, and the diuretic caused hypokalemia, and we gave them potassium? And I think you can see how all of those things develop one on the other. So we have to look at all of the medications that patients are taking. That's the converse of the polypill. But I think we have to look at both sides of the spectrum.
Great. Dr. Wenger, I want to again express our thanks for you're giving this really outstanding and excellent talk. Thank you again very much. And just a reminder to the fellows, to hang on for the next hour for a discussion with Dr. Wenger. Thank you.
Okay, I'm going to have to leave this Zoom because I have a different Zoom number for the session with the fellows. Let me tell you how much I wish I were up there in New Haven, but perhaps that will happen another time. Bye-bye.
Thank you.
Thank you.